Okay, great. Well, I want to thank you all for attending today. So the purpose of today is to really give you an idea of what we would talk about in our three-part treatment plan course. And this is a course that we are going to hold in October 16th and 17th, possibly the 18th. And so today I'm just going to kind of give you some information about, you know, what we do with TalkTools and oral placement therapy, and kind of go into what we look at. And then if you're interested, it would be a great time to sign up to take the class with me. So I just want to give you this content disclosure. I don't make any money from any of the tools that TalkTools sells. I get an honorarium for speaking. I do own my own private practice in Indianapolis, and I see mainly pediatrics from birth to 21 years of age. And I work with a wide variety of diagnoses. I do see some adults for myofunctional therapy, and that's really all I have to disclose. So in the field of speech therapy, traditionally, we are taught that if we want a child to make a sound, look at me, listen to me, do what I do. And for many children, this works great because they have all of their senses are working, and they're able to, you know, look at their parents, they're able to imitate their parents, and they don't need any more input other than just the auditory and visual. And many speech therapists are trained we're trained in the muscles of the mouth, but then that's kind of it. We're not really trained to look any further or to utilize how do those muscles work? How do those muscles affect speech and feeding? So oral placement therapy was developed by Sarah Rosenfeld Johnson, and she is a speech and language pathologist. And what she has done is she has based the theory of this off of occupational therapy and off of physical therapy. So she takes a more muscle-based approach. So she's looking at those muscles of the mouth, and then she's seeing how do they move independently? How can we work on those muscle movements for those children, for those adults, to get clear speech and to get adequate feeding? So when we look at oral placement therapy, this is an approach that was developed back in 1992, and it uses a tactile kinesthetic feedback, meaning that not only are we saying to a client, look at me, listen to me, do what I do, but we're also giving them the feel of speech. So we're saying to them, okay, put your lips together. We may use a tool or a tongue depressor or an apraxia shape, and we're giving them that input so that they know what that feels like to put their lips together. That's the only difference between this approach and between traditional therapy. We would continue to use traditional therapy approaches, but we're adding in this tactile component. So we're really looking at the muscles. A lot of times it would be the equivalent of if you had a physical therapist and the child needed to walk. They would not just say to the child, come on, look at me, do what I do. And they would model walking. They would work on those foundational skills so that then they were able to increase those muscle skills so that they could eventually walk. And that's really the whole concept behind oral placement therapy. It's only one approach. There are many different approaches out there. And usually, as a therapist, I use multiple approaches. I will tell you from my experience, I've almost been doing this 20 years, and the results that I have seen looking at muscle have been amazing. So it really is an awesome way to look at our clients. I like this quote. So, I think this is always really fitting. I did then what I knew how to do. Now that I know better, I do better. And the reason why I put this in here is because oftentimes therapists say to me, oh, I wish I would have known then what I know now. And that's okay. Once you learn about this particular type of therapy, you're not going to be able to unsee it. And it's only going to help you become better. So I hope you will take the journey with me. So what is oral placement therapy? It is a tactile or proprioceptive way of teaching a technique. So traditional therapy is primarily that auditory and visual. Oral placement therapy adds in that tactile approach. It's used to improve the articulator awareness. So we talk a lot about dissociation and grading, and all of these terms that you'll hear, we go through them in depth in the class. And you will become very familiar. They'll become second language to you. All of these are necessary for correct placement for speech clarity. Oral placement therapy is a speech therapy which utilizes a combination of auditory, visual, and most importantly, the tactile component. Many of us need that, how do I feel it? What do I feel? In order to help make that connection. We know that the more input we can give somebody, the more they're going to be able to retain and the more success that they're going to be able to have, because we're using multiple senses of their body. We're using their vision, we're using their touch, and we're using their auditory input. So oftentimes that really is going to help solidify what we want them to do. The first goal, so I thought today I would just kind of, I would tell you about the 6 goals that we're going to talk about in the class. And the first goal is awareness. So awareness is the feel. It's what we want to look at. What is that person's awareness? Are they able to feel where their tongue is in their mouth? Are they able to feel if they're having drooling on their face or building up in their mouth? So really, awareness is the first place that we start. And when we go into the class, we'll actually talk about, how do we work on this awareness? Where do we begin? How do I assess the awareness? And there are many different strategies that we'll use, and those will all be discussed and you will learn in depth in the level 1 class. The second goal that we talk about is to normalize this oral tactile sensitivity. So when we look at awareness, we're actually looking to see, okay, is that child hyposensitive, meaning that they have an under response reaction? Are they hypersensitive, where their system is over responsive? Or are they mixed sensitivity? Or are they fluctuating? And again, we would go into more in-depth information regarding each of these sensory systems in our class. But our second goal would be to try to normalize it. So what I always tell people is that I don't really like the term normal, because what exactly does that mean? we know that if we took a poll of all 500 of us, we're all going to be on a spectrum of normal. So some people like really spicy food. Other people don't, but they're still normal. That means that they can participate in their everyday activities without their sensory systems affecting them. And if we look at a lot of our clients, you might see that, you know, the mom cannot take Johnny to the store because the lights are too bright, and then he begins to throw a fit, or because he's, you know, the sounds around him. So you see him over there holding his ears and rocking. Those would all be ways that that environment is affecting him. And then it ends up restricting people. So they can't go to a restaurant, they can't have family over, or they only are able to eat a certain type of food, and it has to be prepared that way every single time. So really our goal is to figure out what is that awareness, and then it's to normalize it. So get them somewhere on a spectrum where they can participate in their everyday activities. That's our goal. Goal number 3 is to improve the precision of volitional movements of the oral structures for speech production. That is a mouthful, right? So what exactly does that mean? What that means, as traditionally as a speech therapist, we are taught that when we want to assess someone's articulation, we give them an articulation exam that has pictures in it. And we ask them to look at the picture and then say what it is, and then we will transcribe it, okay? So we're taught a lot to listen when we do this. Sometimes we will see a client and we'll be listening and we don't even know what that transcription is, because there is nothing that we're able to transcribe that, or it's really distorted. So we'll mark that on here. But what's more important is that not only are we listening, but that we are looking at that oral structure. So I just want to, this video doesn't have any sound. So it's mainly just, I want you to look at the placement of the person saying two, okay? So they're saying two, like the number 2. And just look at their placement of their articulators. Okay, so you can see that when they say two, the tongue tip is going up to the alveolar ridge, then it is quickly coming down and the lips are rounding out or dissociating from the mouth in order to make the ooh sound, okay? If I were to see a client who was unable to do this, so typically we might see somebody who looks like this, okay? This is a client diagnosed with autism. He's gonna say night, like it's nighttime. And I want you to watch how he says the N and the T sound, okay? So, okay, so the very first time that he says this, if you were not looking at him, you may count that N and that T correctly, okay? He does it really fast, and this is exactly what kids do when they're taking an articulation test. So I'll play it again. Listen to this very first time he says this. Okay? That T, you would probably count that correct because it sounded like a T. However, when you look at his mouth, is he elevating his tongue to the correct placement? And the answer is no, he's not. So is that truly a T sound? No, it's not. In order to make a T sound, that tongue tip is elevated toward the alveolar ridge, and that's where you make it with the correct placement. So I may count that right, which it's not because I was just listening to him. And then I wonder when he gets into co-articulation, when he gets into conversational speech, he sounds like, and I think to myself, where is that T? I thought he had the T sound. He cannot keep that correct placement. He can't keep this compensatory that he's doing in connected speech. So he can use a compensatory at the word level to sound like he's making the T, but it's actually not correct because he's not going to be able to maintain that when we want his articulators to be moving. So one of our goals is that we look at the precision of the movements in order to get intelligible speech. And that's really when we are in the level 1 class, we're talking a lot about is not only listening, but starting to look. Many times, I might, when I'm doing an evaluation, I might see a child, you know, moving their jaw when they're talking. And it's blatantly obvious to me, but then I make it known to the parent. I say, oh, do you see how their jaw is moving every time they speak to the right? And they don't even realize it because when we're with somebody all the time, we become very familiar with those little idiosyncrasies that person is doing. So it's really, really important that, you know, as speech therapists, we start looking at the placement. Our next goal, goal number 4, is to increase the differentiation of oral movements. So what this means is we usually talk about 3 key terms. And the first key term is dissociation. This is the separation of movement based on stability and adequate strength in one or more muscle groups. And in the level 1 class, we will talk a lot about dissociation and actually how we assess dissociation and what it looks like. There is a developmental norm for dissociation. Our bodies are constantly learning to move independently from each other from birth, you know, up until about, oh gosh, I would even hesitate to say, even adulthood, depending on if you're learning a new skill or not. So dissociation is the ability to move one part of that body independently from another part. We see this when we look at the muscles of the mouth. Is that client able to move their lips independently from their jaw? So are they able to go ooh, ee, ooh, ee? Are they able to elevate their tongue tip or depress their tongue tip? So without moving their jaw. And for a lot of our kids, they are not able to do this. They go to elevate, we tell them, okay, put your tongue up on your alveolar ridge so you can say, oh, and they go, or they use their whole head, and you know, they're not able to move that part of their body independently. Our next key term that we use and we talk about is grading. And grading is a controlled segmentation of movement through space based on dissociation. So when we look at grading, grading is the fine, controlled motor movement. So first, my tongue is able to dissociate from my jaw. Then my tongue is able to grade because it has been practicing and it has the strength to move up and down really quickly. When we are speaking in conversation, our tongue is stabilizing on our top teeth and our tongue tip is moving with rapid precision in order to make our speech clear. So grading is something that we will be going into and looking more in depth at. It's also something that we will look at exercises that help with graded movement. Unfortunately, we don't have a lot of time today to go into any of those things. And this is mainly just to kind of give you an idea of what this class would be all about. The last thing that we look at, and we're really good at looking at this one because our clients are really good at doing this, is fixing. And fixing is an abnormal posture which is used to compensate for reduced stability, which inhibits mobility. Now that's a mouthful. And what that basically means is that if my body is not stable and I want to talk to you as rapidly as you want me to, I'm going to find a way to fix. I'm going to find a way to make these movements quick. So I may retract my lips when I talk, okay? Those people that always look like they're smiling, they're not always happy, but they have to do this in order to speak as rapidly as we do. You might see clients that their jaw goes into like a really low position, or they have to, like the little boy that we just saw in the video, they have to stabilize their tongue on their bottom teeth in order to speak as rapidly as we do. However, it's going to affect the intelligibility. So I believe that a child wants to do what you want them to do. And I wholeheartedly believe this. And you may say, well, you haven't seen, Michael. The thing is that kids are going to respond or have a reaction when something is too difficult or when they can't do it. They feel like they're going to fail, and you'll see a reaction or what people call behavior. I don't really care for the term behavior because nobody ever uses it in a positive way. Nobody ever says, hey, he's smiling. He has such a positive, behavior. Nobody ever says that. It's always used negatively. So I like to think of it more as a reaction, because when you think of it something as a reaction, you take away the emotional component and you're able to look at that person unbiased, okay? For us as oral placement therapists, we're like detectives. We're looking at these reactions and these movements, and we're trying to see, what can I do? What tool can I use to help you get the correct placement so that you can feed and you can speak? So that's my main goal. So oftentimes therapists are really, really good at looking at fixing, because these clients will fix in different manners. And that's one of the things that we want to eliminate. We want to get them using the correct movements. All right, our next goal that we have is a little bit should be said here about the Forgotten Articulator. And I thought it was important to put this in here because a lot of times when I ask therapists, what are the 3 primary articulators? I oftentimes will get lips, tongue, and teeth. The teeth don't have anything to do with it. Yes, they will help you have, you know, a little bit clearer speech, but somebody who doesn't have teeth can still have clear speech. Somebody who doesn't have teeth can still eat. That's where the term gummet came from. So what the main articulator that oftentimes people forget or they don't even learn about is the jaw. And the jaw is the primary articulator for feeding and speech. It is the stability of the jaw allows for the lips and the tongue to move independently for feeding and speech. So that jaw stability is like your core strength. You need that stability in order for your lips and your tongue to move independently. Without jaw stability, other muscles are going to come in to help. So if I can't elevate my tongue to my alveolar ridge, my jaw might come in to help. Okay, so I'll see the jaw come up. If my, I may see that if I'm wanting to make an ooh sound and my lips cannot move independently because I don't have stability in my jaw, then I might see lip retraction, okay, because they're trying to stabilize with their jaw in order to make a sound or drink from a straw. It all just depends, okay? So the jaw is, and when we go on our journey in our level 1 class, you will learn how important the jaw is. You will, we'll talk about exercises to assess the jaw and exercises to treat the jaw. Our goal number 5 is to improve feeding skills and nutritional intake. So when we look at feeding is a huge thing. It's a precursor to speech. Oftentimes I say to, therapists, when you're a speech therapist and a doctor says to you, oh, well, they're not talking, they don't need to see a speech therapist, you should be pulling your hair out, because that means that the doctor doesn't understand that we can be looking at feeding. Many of the things we see in feeding, we will see in speech. So if I have a client and they're eating from a spoon, like, it's not going to surprise me that in speech I see mama, baba, papa. They're doing the same movement. We want to correct that movement in feeding. Think about how many times a person eats and how much practice that they get. So if I can teach them to use their lips and to retract their tongue, I'm going to have a lot more success when they get to making PBs and M's. So looking at feeding is important. And when we look at feeding, we look at purees, we look at solids, and we look at liquids. And I look at all 3 of those areas and I see, how are they eating from a spoon? In our class, we'll talk about different spoon placements and what we're looking for when we are doing spoon feeding. We will talk about solids. I'm usually looking at the child eating something that is crunchy, something that is chewy, and something that the parent considers challenging. it's always very interesting to see, what does the parent consider challenging for their child? Is it rice? Is it a piece of fruit? Is it a chip? What is challenging? Is it a piece of meat? Oftentimes, what you'll see is when you start asking parents, parents will come in and they'll say, oh yeah, I'm gonna say, how does their eating? And they eat everything, okay? I never just take that on face value. I always want to see that child eating, because sometimes children will look like they're chewing, but they're not. They don't have tongue lateralization. The food may be all over their mouth, spread out all over their mouth. It may be falling out of their mouth. They may look like they're chewing, and you see that they're mashing the food with their tongue, or they're dumping it with their tongue. So all of those things are going to affect speech. If I can correct them and get them using those muscles appropriately, that is going to play a role in the intelligibility of their speech. So we only have one set of lips. We only have one tongue. How we use them in feeding, we may use them differently than we do in speech, but they're the same muscle. So when we look at this, we really want to see what they're doing in feeding, because that can affect their articulation and intelligibility. I also look at liquids. When I look at liquids, I'm looking to see if the parent comes to me, and I always ask them, bring something that the child likes to drink and what they typically drink from. This is going to be huge, right? If the child is 4 and they're coming in and they're drinking from a bottle, or they come in and they're drinking from a sippy cup, that's the first thing that I'm going to change. Typically, we want to see children off of a bottle by a year of age. Okay, so think about that from a muscle standpoint. Children, when they are drinking from a bottle, they're using this suckling motion. Okay, so this forward and backward movement. What do you need for speech? You need tongue retraction. The same thing is true with sippy cups. Sippy cups are nothing more than a grown-up bottle. That's all they are. And a lot of times people say, well, my child drank from a sippy cup and they're fine. We're not talking about children that have appropriate muscle skill. We're talking about individuals who may have difficulty or have muscle weakness. So those are the types of individuals that they shouldn't be doing a sippy cup. And really, in my opinion, no one needs to do a sippy cup. We're seeing more frontal lisp. We're seeing more children with dental cavities because they're drinking from a sippy cup all day long. Children are now starting to use those sippy cups to self-soothe. So you'll see parents say, oh, you're upset, here, take a drink, okay? And what's the kid over there doing? Suckling, basically. We know that one of the primary spots in our body for organization is our temporomandibular joint. Proprioception in general is good to help us organize and regulate ourselves, but we get a lot of input through our temporomandibular joint from speaking and from eating. We will see people try to give themselves stimulation to this area in other ways as well. Teeth grinding, thumb sucking, biting on pen caps, biting your fingernails, chewing gum. All these are ways in which to give yourself input to help yourself calm and to be able to either increase your attention, increase your focus, participate, all of these things, or just to calm yourself. So all of those are ways in which people will give themselves those inputs, and that children are no different than adults in that way. If they can't speak or they can't eat, they're going to find another way to give themselves that input. They might start chewing on their shirt. They might bite themselves. They might grind their teeth, suck on their tongue, all these things. So, and we will go more into depth in that in our level 1 class. When I look at liquids, I want to go to straw drinking and to cup drinking. And straw drinking, in the level 1 class, we'll talk about the hierarchy. There are 8 straws in our hierarchy, and each of those straws works on more and more tongue retraction. So we will discuss that as well. And I'll teach you what to look for and what the criteria is. So feeding is very, very important, and we spend quite a bit of time on looking at feeding in our level 1 class. Our last goal is to improve speech sound production to maximize intelligibility. And this really is what it's all about, right? As a speech therapist, you know, my number 1 goal is to be able to get someone to communicate by whatever means necessary so that they can make their wants and their needs known. We are all very social beings. You know, I say that some people aren't as social as others. That's okay. But a lot of people get enjoyment from talking to someone or communicating with others. And this is something that, you know, being able to express if you are happy, if you are sad, if you are hurt, is really, really important. And we want to be able to have, you know, individuals have the intelligibility to make their needs known. And that really, you know, if you ask a lot of speech therapists, this is why they go to school. They want to help people communicate. However, what we see when we are going through this is that sometimes you can't start right at a sound. Sometimes I have to start with feeding. Sometimes I have to go all the way back and start at goal number 1, which is awareness. Do they even feel their lips? Do they even know where their tongue is? So a lot of times this is, it will take me some time to get to my main goal, but I eventually will get there. And that's what is really, really important. So when we are doing our level 1 class, we will go into depth about how each of these goals, how we evaluate them, how we, what we use in a TalkTools oral placement program. Sarah basically looked at muscle, and then she said, okay, I'm going to use a tactile approach to get that muscle ready to make a movement. A lot of our therapy is based on the sensory, what do I feel, motor, can I get that movement using a tool or the feel, adding in that tactile component, and then the movement. So if I want somebody to say, I might use a toothette to see, do they have the awareness in their lips? I might use an apraxia shape to give them that feel of what their lips feel like together. I might have them practice side placement spoon feeding in order to work on that movement. And then I'm going to put that movement into production. So I'm constantly looking at sensory, motor, movement. Everything I do is that. And oral placement really isn't something that it's the only thing you do. It never is the only thing I do. I'm a speech and language pathologist, so I am constantly doing language. I'm constantly using my traditional approach. You have to use that. If I were to just do oral placement, yeah, a child may get better with their sound, but if I don't follow it up with function and having them practice that, they might just be somebody that can hold bite blocks or do chew tubes, but they still don't have intelligible speech. So it's really, really important that we follow these skills up with our traditional approach to speech therapy, in our traditional methods that we normally use. I'm constantly using function as soon as I get a movement. And we will go into great detail about that in our level 1 class. I just want to show you, this is a little girl. She is 7 years old, so she is getting ready to enter kindergarten, or first grade. She just finished kindergarten. And she has Down syndrome. And you can see, look at her mouth at rest, okay? This is what a child with Down syndrome should look like. Children with Down syndrome are not born with their mouths hanging open. Many diagnoses, for that matter, those children are not born in those positions. They usually get to those positions through improper feeding or through difficulties muscle-wise that they have that are never addressed. So I just want you to listen to her speech.
What's your name? 7. And how old are you? 7. And what do you like to do? I don't know. You don't know? Do you like to swim? Yeah. Yeah? Who is swimming with you today? Emerson. Who? Emerson. Emerson. Emerson? Tucker. And Tucker? Yeah. Okay. And who are they? Cousins. They're your cousins? Yeah. Yeah. And what grade are you going to be in? 1st grade. 1st grade. Wow. Are you excited for school? Yeah. New school. Your new school? Yeah. Do you know the name? I don't know. No, you don't remember? I don't remember. Okay.
Okay, so I just wanted to show you, obviously she's not finished with therapy, but some of the nice things that you can see is that she's getting some S's in the correct placement, some Z's, cousins, when she says that. Her tongue is retracted, her teeth are together. She's still kind of fixing a little bit here in her mouth. So she kind of, is here. She's being a little shy. So I think some of that has to do with what you're seeing here. If I can get her in a more relaxed position, you would see that, she'll talk your ear off. But you look how she's breathing through her nose, her mouth is closed. She's got really good skills. And on top of all of that, she's doing really, really well in school. We've taught her to read, and she's above her class level with typical peers in reading. So I just wanted to show you kind of what oral placement can do for someone. And she's going to have a much better opportunity in life because she can communicate and because her speech is going to be intelligible. When I work with a child and they go into school and they're speaking clearly, what does that do to a teacher? When they go, and I can teach them to go into school and they're able to read, what does that do to the teacher? That makes the teacher say, oh, okay, you can do this. Let's go for it. it changes the way people look at the possibility. And I feel really, really strongly about that a lot of times just because somebody can't communicate doesn't mean that they don't understand. It does not mean that they cannot learn. It doesn't mean that they can't talk. I am always going to look at what I have in front of me, where I want them to be, how am I going to get them there? And the brain is amazing. It can do amazing things. So I look at it as, what are the possibilities? And that really, to me, is what it's all about. Let's see how far we can take you. Let's see how far you can go. Okay? I like this saying as well. The only true wisdom is in knowing you know nothing. You know, when I first started practicing, I said to myself, I would see these other therapists and I would see like, wow, how well they were doing and how much knowledge they had. And I thought, oh, I can't wait until I've been practicing 5 years. For some reason, 5 was like the magic number for me. And I thought, I'm just going to have so much more knowledge. And let me tell you, it has never changed. I always feel like I know nothing. And I'm constantly looking to learn something new. And to be able to help my clients be better people and to have success. So it's okay to feel like you don't have a clue on what I'm talking about. My hope is that you will take the level 1 class with me and that we will go on a journey together to help your clients be successful. I appreciate every single one of you that attended today. And thank you for listening to me. Again, I hope you will take the class and we can, make a difference. I, at this point, will take any questions that you may have.
Thank you so much, Monica. If you could stop the screen share, then we can have you complete in the picture.
Sure.
Okay, so there's one question from an audiologist. In the speech production, is OPT providing movement cues or just placement, tactile feedback?
So it's providing, I would say both of them. When you say movement cues, what exactly do you mean by that? So it is providing a tactile cue to get correct placement, but then we're going to be practicing that placement in movement. And so we may need to add in more tactile cues or stability in order to work on that muscle for movement. Hopefully that makes sense.
Okay, so there is a question from a parent. At what age can we start OPT?
So if a child has a diagnosis, I want to see them at birth, okay? Because I can prevent a lot of speech sounds from happening by looking at their feeding in infancy. And so this is what I'm really trying to educate speech therapists about, is that we need to be in there looking at how that child is eating. So we can start, this particular program goes from birth to geriatrics because we're looking at muscle, and muscle is muscle. It doesn't matter how old a child is. They could come to you at 15 years of age. You're going to be looking at where their muscle skill is. You can do some things to help improve that muscle and improve the placement to get them to have intelligible speech. It may just take longer because you're dealing with, habitual patterns, which sometimes the older they are, the harder to break, but it can be done.
The next question is, how will oral placement therapy help a child with autism?
I've seen oral placement help a lot of children with autism because what is the issue, right? They usually have trouble communicating, and they're also doing a lot of, there's usually a sensory component to this. So usually you will see that it could be that they don't like being touched, okay? So then that's where we have to start. It could be so that then later we can help them get the correct placement. It could be that they don't have the awareness or the feel of what even their muscles are supposed to be doing. A lot of times I find that when I can give them that awareness and I can get those muscles moving, okay, then I'll start hearing them babble. That's what we want, right? If they're doing echolalia, that's what we want. That tells me that it's in there. It's all a way about unlocking what's in there. And I really do believe that. And so I also believe in multimodality communication. So while we're working on here and speaking, sometimes those individuals need an augmentative device to help them actually be able to communicate. We can't wait until all of this is good in order to give somebody a voice. We have to work on both of those things simultaneously. It's never, in my opinion, this or a that. It's what, okay?
Correct. Very true. Aradhana, do you want to take a few questions? Is Aradhana here with us? Let me just check quickly. Okay. So can drooling be controlled with OPT for a 7-year-old child?
I would tell you that yes, because it just depends on what the underlying reason for the drooling is. And in our level 1 class, we actually go into different reasons that someone could be drooling. And then we discuss different activities that we can use to assess that, where the breakdown is, and then to help them. You know, so it could be that they have jaw weakness. It could be that they have lip weakness. It might be that they don't even feel the drool in their mouth, or it might be that they don't have tongue retraction. So we go into a lot of detail in that level 1.
Monica, is there any hierarchy in OPT to teach sounds in children with articulation errors?
I don't know if I know what they mean. Like a hierarchy with how we teach sounds?
Yeah. Yeah.
Okay. So I would say that, you know, we typically use our traditional approaches when we're teaching sound production. I usually start with vowels, and then I would move to early sound production like MPs and Bs, and then go up to, you know, Ks, Gs, Ts, and Ds, Ns, Ls. It's just your traditional method of speech therapy that you may have learned about. I use Nancy Kaufman's approach a lot in conjunction with oral placement. She looks at like vowel consonant combinations, and we do talk more about this in the class as well.
Sorry, I was mute. Monica, can you share your experience with oral placement therapy with children with Down syndrome?
My experience with using oral placement therapy is with children with Down syndrome is it's basically a no-brainer because oftentimes they have muscle weakness, or it's to me the missing piece. Looking at muscle needs to be done. And not only with children with Down syndrome, but cerebral palsy, CHARGE syndrome. We see a lot of different syndromes and genetic cases at my clinic. And I would tell you, even just strictly articulation kids, sometimes when those kids are, you know, later in like 3rd grade and they still aren't getting the sound, or they're in 2nd grade and they're still not getting the sounds, there's usually an underlying muscle function. We see that a lot. And, you know, when the kids just keep going on and on and on in school, working on speech, it's often because no one has addressed that underlying function. The results that I've seen with Down syndrome have been amazing. And you can see, like, you know, we'll look at some pictures and videos in level 1, but just even the little girl that I just showed you here, you know, she has really intelligible speech, and you can understand, you know, pretty much everything that she's saying. So it's, I always tell parents, there's no reason why a child with Down syndrome cannot have intelligible speech. So it's just a matter of how we get there and what we work on.
So one of the question is, can we work for speed of speech for a child with cerebral palsy who's an adult now?
I'm always going to tell you it's worth a try, right? If you don't try, then you're never going to know. So the way I approach those situations is, yeah, let's work on muscle function. If I can get you to have better control over your muscle function, then we can work on speed. But you have to look at that underlying foundational skill. And I'm never going to say to somebody, you know, let's not do it, because that means I'm not even going to try. And so we have to try. Okay, if you do something and you do it for 2 months and it's not working, then maybe you need to look at a different approach. If you're seeing results, you keep going.
Correct. Is there also any hierarchy for food type in feeding assessment?
Food type. So it depends on what the difficulty is for a client, right? We will always look at purees. We will always look at using some sort of meltable before you do something that's extremely hard. A lot of times these children that have muscle-based deficits, they have difficulty with the parent. You will ask the parent, well, what is their typical diet? And they'll say, oh, they eat macaroni and cheese, they eat yogurt, they eat rice, they eat noodles. And you notice that all of those things are really easy to chew. Crackers, they're very easy. So that tells me that their system is unable to do more difficult foods. Children know what they can and cannot handle. And so they're going to prefer something that they can handle because it's going to be easier. So what do we want to do? We want to work up to being able to support those more difficult foods.
So someone has asked a question. Can you explain the difference between a traditional placement therapy technique and OPT?
So traditional placement would be, I want somebody to say the sound. I'm going to say, look at me, listen to me, put your lips together. And that's what I'm going to do. That's traditional therapy. That's what we're taught in school. An OPT method might be, and I don't really have anything like right near me, so I'm just going to get something that I have near me, which might be like an index card or a piece of paper. And I would say to them, I want you to say, So now I'm giving them the feel of their lips coming together. Okay, it's just adding in a tactile approach. If it's a, apraxia shape, I might be going, It's just adding in that feel. That's it. Okay, that's the main difference.
That you talked about apraxia. How can we use TalkTool with a child with apraxia of speech?
Okay, so a lot of times people say, well, you know, a true apraxia doesn't have muscle weakness. They just have motor planning. So if I say to them, say, they may go B, or they may say B, or P, or something completely different. When I use oral placement with apraxia, because a lot of times those individuals need that tactile cue to get the correct placement. And then what we do is we practice that over and over and over again, which is where the motor memory movement comes in. So that's how it helps the apraxia. If I'm having them blow on a horn number 1 is a really easy horn to blow. It's also a flat-mouthed horn. So if they blow on this horn, they're going to be going, because I'm having them practice that in and out of their mouth, I'm practicing this motor movement. So that's one of the reasons why I might use it for someone who has apraxia.
Shall I ask one?
Sure, Aradhana, go ahead.
Yeah. Someone has asked, is oral placement therapy principles same as prompt? Principles of prompt?
It's a little bit more in depth than prompt. I would say that, you know, the majority of us on the TalkTools team who are oral placement specialists, we're also trained in prompt. Prompt uses those tactile cues on the outside of the mouth. We tend to use a lot of cues on the inside of the mouth. Some of the research shows that when you can stimulate inside the mouth, the clients are able to retain it a lot better. However, I will tell you that I don't look at oral placement or prompt. I look at them as different techniques, and if I need to use prompt, I'm going to use prompt. If I need to use oral placement, I'm going to use oral placement, or I could be using both of them at the same time. Oral placement really looks at those underlying stability issues that the client might have. And so we look at, you know, those key terms of dissociation and grading. I know prompt looks at them as well. However, we're using, ours is kind of like an exercise program, right? So how many reps can you do? What's the point of failure? Individuals, you know, some individuals get it with prompt. Some individuals, you do prompt and they're still not making any headway. You need to look at those underlying muscle skills. And when you start addressing them, then you can add prompt back in and it works great.
Okay, one parent has asked, my kid eats all kinds of foods but is not verbal yet. With OPT help?
So yes, just because the child, what we would have to do is figure out, okay, why are they not verbal? Can they make a sound on command? And if they can't, that's where we're going to start. Is their sensory system so affected that they're unable to process multiple modalities of information coming into them? So we may just need to look at and always asking the question, why? Why aren't they doing it? Usually there's a reason that they're not, or they just haven't been stimulated in the right way.
Does it help in teeth grinding is another question. Teeth grinding, and what does it indicate?
So yes, oral placement can help in teeth grinding because obviously there's an underlying reason that that person is teeth grinding. So is it because they can't, they're not able to get the information that they need from eating difficult foods and from speaking? Are they getting the teeth grinding because there's too much sensory happening to them and they need to try to calm themselves? There are definite questions that we ask when we're looking at teeth grinding. We have our bite tube hierarchy that we can often put children on that helps them get that input to their temporomandibular joint. We're also usually probably working in conjunction with an occupational therapist who specializes in sensory integration to kind of help regulate that body so that we can diminish that particular input that they're getting. They could get it more appropriately doing something different.
There's another question. Does it help in thumb sucking, and how?
Well, yes, it can help in thumb sucking. Thumb sucking is basically, another way of, a child trying to seek that regulation. So it's promoting that forward and backward tongue movement, which is giving stimulation to that temporomandibular joint. It has a lot of myofunctional reasons. So for thumb sucking, I would also be looking at where is that tongue tip resting in the oral structure? Is it resting on the palate? If it's not, excuse me, if it's not, then they're probably not going to get that that organization and that sensory input that they would normally get. Their thumb is going to be giving them that input. So on the roof of your mouth, just toward the front, you have a little bumpy ridge. Behind that is a little spot. And when your tongue rests on that spot, that's where your tongue should be resting. When your lips are together, it should be resting there all the time. When it's resting there, it's releasing serotonin and endorphins. That's what makes you feel regulated. And if it's not resting there, we're going to find another way. We're going to put our thumb there to give the stimulation, right? So we look at all of that and then can, help decrease the thumb sucking, which would ultimately change the shape of the palate, affect alignment of teeth. Okay.
Yeah, can OPT be taken online, and do you have any experience with that in providing therapy online and assessment online?
So you can, I believe that you can take the level 1. You can take the level 1 online. There's a...
No, sorry, it's like, do you provide therapy for the child and assessments for the child online? So after doing the online training program, can we start seeing the kids for online therapy by using OPT?
So, this is a very interesting question, right? Because with the pandemic and COVID-19, we've had to go to doing teletherapy. I would tell you that when you're first starting OPT, it's going to be better to start with a child in person because you are going to need to touch them, okay? If you are familiar with doing OPT, it might be something that you would have to train a parent and they would have to be your hands. So oftentimes, like, I will tell the parent what I want them to do, and I'll be looking at those reactions and educating the parents. So it can be done. However, when you're first learning it, you're probably going to be limited in what you can do because you're really going to need to feel what's happening to understand it better.
There is another interesting question. It says speech is required for integration of articulators, but if we teach the individual sounds via oral placement therapy, then doesn't it break up the word like at instead of speaking the whole word?
So no, what we're doing is we're not actually breaking up the word. It could be that I want to make sure that they can say k instead of saying t, right? So do they have tongue retraction? And that's what I'm looking for. If they don't have tongue retraction, then I might be using a feeding technique or a straw technique to help them get tongue retraction and practice that motor movement and then put it into production. So if, you know, they say tat, then I already know they can say act, right? That's already there. But now I've gotten the tongue to retract for the k, and now I can work on cat and getting that, you know, just like you normally would. And then K, 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 key, key, key in your traditional approach. Okay?
There is another very important question. If speech is normal, can anything be done to increase the loudness?
Okay, so in my experience, you would have to look at, you know, why is that child speaking softly? Is it an awareness thing? Sometimes if they are dealing with ear issues, they might sound louder to themselves. So if you've ever, I guess the best way to put it is if you've ever had in earphones and then you're talking to somebody, you might talk louder because you feel like they can't hear you, or you might talk a lot softer because you can hear yourself being very loud. It could be that. It could be a sensory thing. We have to figure out why is that. And sometimes it's just even awareness. The child doesn't even know that they sound that soft. So we just have to teach them discrimination.
There is another question. If a child with autism has so much of sensory issues, then how can OPT help?
Well, if a child has a lot of sensory issues, I mean, OPT can help because that's where we're going to start, is we're going to start looking at their overall body sensory system. We're going to make appropriate referral if we need to, but we're also going to be working in conjunction with those other therapists. So ideally, if, you know, what we're going to do is slowly work on toleration of either touch, sight, feel, and until we can get, you know, inside their mouth or get their mouth to tolerate different things. You know, I always ask parents, you know, how does your child do with teeth brushing? And if the parent says they have to, like, basically, you know, hold that child down to brush their teeth, you know, that gives me insight into their sensory system. There's a lot of information that I can gain about the sensory system just by asking the parents questions and watching that child eat.
Is there any upper age limit for OPT to be helpful to the individual?
No, there is no upper age limit.
Jasmeet, do you have any more questions?
Oh, you're on mute.
There was a question on hyposensitivity. How would you work with a child with a hyposensitivity?
Hyper or hypo?
Hypo.
Hypo, so under responsive. So he's great for that. I mean, it's great with both of those sensory systems. How you work on things is going to be different depending on what their sensory system is. For somebody that is hypo or under responsive, you're going to be giving them that tactile input. So that under responsive system, depending upon where in the body it's under responsive, that will tell you then what you need to do in order to get that muscle to move. So for example, if I have somebody and I want to work on lip rounding and they're under responsive, I might take a toothette and stimulate inside the mouth. When I do that, I'm looking for a reaction. If I can get a reaction, ooh, now I've just used a tactile cue. I've given them another form of information for their body to make that connection of movement, okay?
One more question. If the speech is clear but no chewing, what should OPT be focusing on as a therapy? Where should you be focusing on?
In my opinion, you should be focusing on the chewing, right? So I would be looking at jaw stability, I would be looking at jaw grading activities, and then I would be following that up with functional feeding activities. So, you know, whether it's a slow feed or solid cube placement, we would want to be practicing that movement in function.
Can you give any suggestions for individuals with problem with dissociation in movements?
Okay, so say that again. Give any suggestions for problems with dissociation?
Of movements, yeah.
Where? In the mouth?
Yeah.
So in our class, we will actually talk about what the dissociation looks like, and then we'll actually go into more specific examples about how you can teach the child's motor movements or muscle movements to have better dissociation. So it's hard to say without knowing like exactly what the person is talking about. But like, for example, if I want the tongue to lateralize, okay, to move independently from the jaw, I might be working on some jaw activities because this is my stability. And then I would be working on those lateralization activities, which there's probably, I mean, over a handful of different activities that you can do to help facilitate that tongue lateralization and doing it over and over again, building that motor plan and that motor movement.
Sure. Okay, I think one more question from my side. When we choose OPT goals, does it have to be hand in hand with other occupational therapy oral motor goals?
So what do they mean by that? Does it have to be hand in hand? So like what, can they give me an example?
So I'm going to ask the person who asked this question to give an example, but I think what she meant was that if I have some oral motor goals in general, then OPT becomes, we should go hand in hand. I mean, obviously, yes, but let me see what she gives an answer back.
Okay.
If that is what she had in mind. Okay. One of my kids can imitate sounds, but not words. Can we try OPT with the child?
Yes, most definitely. Yes. Remember that the mouth is a fine motor movement. So oftentimes an occupational therapist is going to be working with a child, or maybe even a physical therapist, working on gross motor and fine motor movements. We have the finest motor movement of the body, which is in the mouth. So we oftentimes will be working with them in conjunction to whatever other goals that child may be working on. And we need those other people because, you know, they're like our best friends, right? I mean, we need them to be working on those things so that we can make as much progress as possible.
Absolutely. Aradhana, do you have any questions?
You're on mute.
No,
Can OPT resolve humming in kids with ASD?
Can it resolve humming? So again, I would look at why are they humming, right? So when you hum, you're getting an auditory input. Remember that we cannot take away an input unless we have something to replace it with. So could we replace that humming with them getting more input through speaking? You know, could, also I would probably say they need to work with an occupational therapist to work on that sensory component overall of either proprioception or auditory input. There's a reason why they're humming, and it could just be the vibration that they're getting in that temporomandibular joint as well.
There is one last question. One of my kids can imitate sounds but not words. Can we try OPT and will it help?
Yes, yes. Most definitely.
Okay.
Okay.
Do we have time for any more? I don't think so.
Just
I don't think we have time for any more because Monica's got to get into another meeting. So I think a big thank you to Monica for taking time out in these difficult times for this webinar, which I'm sure most of you liked. And I would request Jasmeet and Aradhana to say a couple of words and thank Monica for the same. And a thank you to all the participants for taking out time to attend this. We will keep you updated on the workshops, which will be announced soon.
And I hope you all will come and join me. It's going to be fun.
Monica, I still need you to stop the screen share. And participants, can you please switch on your videos and let Monica see all of us?
How do I stop my screen share? Oh, here we go.
Let's go to the bottom ribbon. Yeah.
Perfect.